Management of patients with HIV. Human immune deficiency virus, or HIV, can only be spread from one person to another through certain body fluids from an HIV-infected person. HIV-1 is transmitted in body fluids that contain infected cells. These body fluids are blood, semen, preseminal fluid, rectal fluids, vaginal fluids, and breast milk. These body fluids must come in contact with a mucous membrane or damaged tissue or be directly injected into your bloodstream for transmission to possibly occur. An example would be a needle or syringe. Mucous membranes are the soft, moist areas just inside the openings to your body. They can be found inside the rectum, the vagina, or the opening of the penis and the mouth. The most common way HIV is spread is by having unprotected sex with someone who has HIV. HIV is also transmitted by sharing needles, syringes, rinse water, or other equipment used to prepare injection drugs with someone who has HIV. Less commonly, HIV may be spread by being born to an infected mother, being stuck with an HIV-contaminated needle, or other sharp object. Also, oral sex and other fluid-to-fluid interactions. HIV is not spread by air or water, insects, including mosquitoes or ticks, saliva, tears, sweat, casual contact like shaking hands, hugging, or sharing dishes, drinking glasses, drinking fountains, or toilet seats. Despite advances in treating HIV, acquired immune deficiency syndrome, AIDS, remains a public health issue. Prevention, early detection, and ongoing treatment are important aspects for care. Nurses need to help in efforts to prevent HIV infection by educating how to eliminate or reduce risks associated with HIV infection and AIDS. Behavioral interventions have been effective in reducing the risk of acquiring or transmitting HIV by ensuring that people have the information, motivation, and skills necessary to reduce their risk. Infected patients should be educated to change their behaviors to protect their partners. Patients should be linked to testing, treatment, and care, which enables individuals with HIV to live longer, healthier lives and reduce their risks of transmitting HIV. Lastly, all education programs should focus on control and prevention. Specific strategies to protect against HIV infection should include advising all sexually active patients to reduce the number of sexual partners to one. Always use latex condoms. If the patient is allergic to latex, non-latex condoms should be used. However, they will not protect against HIV infection. Also, never reuse condoms and avoid sharing needles, razors, toothbrushes, sex toys, or blood-contaminated articles. Patients who are HIV seropositive should be advised to take antiretroviral therapy regularly to achieve viral suppression. They should inform previous, present, and prospective sexual and drug-using partners of their HIV-positive status. If the patient is concerned for their safety, advise the patient that many states have established mechanisms through the public health department in which professionals are available to notify exposed contacts. They should avoid having unprotected sex with another HIV seropositive person. Cross-infection with that person's HIV can increase the severity of infection. All HIV patients should be advised to not donate blood, plasma, body organs, or sperm. Pregnant HIV patients should be educated their baby can become infected with HIV in the womb, during delivery, or while breastfeeding. If the mother does not receive treatment, 25% of babies born to women with HIV will be infected by the virus. With treatment, that percentage can be reduced to less than 2%. Babies born to women with HIV receive HIV medicines for 4 to 6 weeks after birth. Implementation of appropriate hand hygiene measures remains the most effective measure to prevent transmission of organisms. To reduce the risk of exposure of healthcare workers to HIV, the CDC developed standard precautions. You should study Chart 36-5 on page 1029. Healthcare workers who are exposed to a needle stick involving HIV-infected blood in a healthcare setting have a 0.23% risk of becoming HIV infected. The risk of infection due to occupational exposure is very low. If you sustain an occupational exposure to HIV, take the following actions immediately. Notify your supervisor immediately. Undergo immediate HIV testing to obtain a baseline and retest at 6 weeks, 12 weeks, and 6 months after exposure. HIV is the subfamily of lentivirus and is a retrovirus because it carries its genetic material in the form of ribonucleic acid, RNA, rather than deoxyribonucleic acid, DNA. HIV targets cells with CD4 positive receptors which are expressed on the surface of the T lymphocytes, monocytes, dendritic cells, and brain microglia. There are 5 stages of HIV infection based on clinical history, physical examination, laboratory evidence, signs and symptoms, and associated infections and malignancies. The period from infection with HIV to the development of HIV-specific antibodies is known as the primary infection or acute HIV infection and is part of Stage 0. Stage 1 or acute HIV infection is the interval between the appearance of detectable HIV RNA and the first detection of antibodies. Initially, there's a period during which those who are HIV positive test negative on the HIV antibody blood test, although they are infected and highly infectious because their viral loads are very high. About 40 to 80% of patients develop clinical symptoms of a nonspecific viral illness lasting 1 to 2 weeks. By the time neutralizing antibodies can be detected, Stage 1 is firmly established in the host. Once the primary infection with HIV has subsided and an equilibrium exists between the HIV levels and the patient's immune response, a viral set point has been reached. After this viral set point is reached, a chronic stage will begin where the immune system cannot eliminate the virus despite its best efforts. During the first stage of HIV infection, the patient may be asymptomatic or may exhibit various signs and symptoms such as fatigue or skin rash. Stage 2 occurs when CD4 T lymphocyte cells are between 200 and 499. Stage 3 when the count drops below 200 of blood, and at this point the person is considered to have AIDS for surveillance purposes. A Stage 3 diagnosis has implications for services such as disability benefits, housing, and food stamps. HIV disease progression is classified from less to more severe. Once a case is classified into a surveillance severity stage, it cannot be reclassified into a less severe stage even if the CD4 positive T lymphocyte increase, which often occurs when a person receives ART. Cases with no information on CD4 positive T lymphocyte count or percentage are classified as stage unknown. Patients who are in later stages of HIV infection may have a variety of symptoms related to their immunosuppressed state. These symptoms can include dyspnea, cough, chest pain, and pneumonia. Gastrointestinal manifestations can include loss of appetite, nausea and vomiting, oral candidiasis, diarrhea, and wasting syndrome. Oncologic manifestations such as Kaposi sarcoma and age-related lymphomas. Neurologic manifestations would include a progressive decline in cognition, motor function attention, peripheral neuropathy, depression, and apathy. Integumentary manifestations would include herpes zoster, dermatitis. Gynecologic manifestations can include genital ulcers, recurrent vaginal candidiasis, pelvic inflammatory disease, and menstrual abnormalities. New drugs that offer new mechanisms of action, improvements in potency and activity when against multi-drug resistant viruses, dosing convenience, and tolerability have been approved. The overarching goal of ART is to suppress HIV replication to a level below which drug-resistant mutations do not emerge. Related goals are to reduce HIV-associated morbidity and prolong the duration and quality of survival, restore and preserve immunologic function, maximally and durably suppress plasma HIV viral load, and prevent HIV and transmission. In the United States, ART is now recommended for all HIV-infected patients, regardless of their viral load. Nurses should be vigilant in addressing any barriers preventing patients from obtaining medications. Nurses' assessment includes identification of potential risk factors, including a history of risky sexual practices or IV injection drug use. The patient's physical status and psychological status are assessed. All factors affecting immune system function are thoroughly explored, and a number of instruments can be used to assess symptoms and self-management strategies. Nutritional status is assessed by obtaining a dietary history and identifying factors that may interfere with oral intake, such as anorexia, nausea, vomiting, oral pain, or difficulty swallowing. The skin and mucous membranes are inspected daily for evidence of breakdown, ulceration, or infection. Respiratory status is assessed by monitoring the patient for cough, sputum production, shortness of breath, orthopnea, tachypnea, and chest pain. The presence and quality of breath sounds are also assessed. Other than the level of consciousness, the patient is assessed for sensory deficits like visual changes, headache, or numbness and tingling in the extremities, altered gait, and seizure activity. Fluid and electrolyte status is assessed by examining the skin and mucous membranes for turgor and dryness. Every chance a nurse gets, they should educate their patients regarding self-assessment information. A list of priority nursing diagnoses for patients with HIVs could include diarrhea related to enteric pathogens, risk for infection related to immune deficiency, ineffective airway clearance related to increased bronchial secretions, imbalanced nutrition, less than body requirements, deficient knowledge related to means of preventing HIV and transmission, social isolation related to a number of factors such as stigma of the disease, withdrawal of support systems, isolation procedures, and fear of infecting others. Your goals for the patient may include achievement and maintenance of skin integrity, resumption of usual bowel patterns, absence of infection, improved activity tolerance, coherent thought processes, improved airway clearance, increased comfort, improved nutritional status, increased socialization, expression of grief, increased knowledge regarding disease prevention and self-care, and absence of complications. Promotion of usual bowel patterns by assessing the patient for diarrhea. As the patient's dietary intake is increased, foods that act as bowel irritants such as raw fruits and vegetables, popcorn, carbonated beverages, spicy foods, and foods of extreme temperatures should be avoided. Administering anti-diarrheal agents on a regular schedule may be more beneficial than administering them on an as-needed basis. The patient and caregivers are instructed to monitor for signs and symptoms of infections such as fever, difficulty breathing, skin irritations, unexpected weight loss, swollen lymph nodes, nausea, vomiting, persistent diarrhea. The nurse also monitors laboratory test results that indicate infections such as the white blood cell count and differential. Respiratory status, including rate, rhythm, and use of accessory muscles and breath sounds, as well as mental status and skin color, must be assessed at least daily. To improve airway clearance, the fluid volume status is evaluated so that the adequate hydration can be maintained. Nutritional status is assessed by monitoring weight and dietary intake. The patient is also assessed for factors that interfere with oral intake, such as anorexia, esophageal candida infection, nausea, pain, weakness, fatigue, and lactose intolerance. Based on the results of assessment, the nurse can implement specific measures to facilitate oral intake. The dietitian is consulted to determine the patient's nutritional requirements. The patient and family are educated about HIV infection, means of preventing HIV transmission, ART, and appropriate self-care measures. When patients are newly diagnosed, it is important to inform patients treatments have been improved dramatically and the patient can potentially live a long and full life. Nurses in all settings are called on to provide care for patients with HIV infection. In doing so, they encounter not only the physical challenges of this epidemic, but also emotional and ethical concerns. The concerns raised by healthcare professionals involve issues such as fear of infection, responsibility for giving care, values clarification, confidentiality, developmental stages of patients and caregivers, and poor prognostic outcomes. Many patients with HIV infection have engaged in stigmatized behaviors. Because these behaviors challenge some traditional religious and moral values, nurses may feel reluctant to care for these patients. In addition, healthcare providers may still be afraid and anxious about disease transmission, despite education concerning infection control and the low incidence of transmission to healthcare providers. Nurses are encouraged to examine their personal beliefs and to use the process of values clarification to approach controversial issues. Education and provision of up-to-date information help to alleviate apprehension and prepare nurses to deliver safe, high-quality patient care. Interdisciplinary meetings allow participants to support one another and provide comprehensive patient care. Staff support groups give nurses an opportunity to solve problems and explore values and feelings about caring for patients with AIDS and their families. They also provide a forum for grieving. Other sources of support include nursing administrators, peers, and spiritual advisors. Nurses are responsible for protecting the patient's right to privacy by safeguarding confidential information. Inadvertent disclosure of confidential patient information may result in personal, financial, and emotional hardships for the patient.